Good morning, and thank you for joining the Swim Towards Stewardship Webinar 2 on measurement. We're going to get started this morning, but before we do, we'd like to give you a few instructions on our session today. Reminders that this session will be recorded and transcribed, and team leads will be receiving a recording link where they can access this presentation at the beginning of next week. That recording link, along with the slide deck, will also be posted to Innovation the beginning of next week, along with any other resources referenced by our presenters today. We want to make sure to tell you a little bit about the Zoom webinar platform we're using today. Registration was required for today's event, and after you registered, you should have received a link or an email with a Zoom link to join today's webinar. When you clicked on that link, you would have seen a screen similar to this, and to give you some options on dialing into today's audio. You can always click join by phone or join by your computer screens. For the purpose of today's session, if you're not a panelist with us today and are attending in a view-only mode, your lines have been muted. If you're having trouble with today's audio, please do in the bottom left-hand corner of the screen, you'll see kind of a headphone set that says join audio. Go ahead and click that link and it'll provide you this login information. At the bottom of the toolbar here, you're going to be able to see some functionalities as a participant in today's webinar. Towards the middle left, you'll see a chat function. If you use that box and pull it up, you'll notice that there is a section towards the bottom of the chat box where it says to, and you can use the down arrow to select which audience you'd like to send your chat messages to. We'd encourage you to select the option that says all panelists and attendees, and this will enable folks that are participating in the fishbowl and also from the sandbar to be able to see our conversations, discussion, and question and answers as they flow through today's chat. In the middle, you can always use the raise your hand function if you have a question, or type any questions that you may have for today's presenters into the Q&A box. At this time, I'd like to welcome you all to the fishbowl. As you know, we've got 4 hospitals that are participating in the fishbowl for these series. And before we turn to them, I'd like to send a special welcome and thank you to those of you that have joined us from the sandbar. It looks like we've got just over 30 different hospitals in attendance on today's call, so thank you very much for being here. At this time, though, we'd like to turn to the hospitals participating in the fishbowl and ask their team leads, again, just to introduce themselves and their facility, and maybe key us in on one of the key things that their hospital team has been working on this past month. So Joe Chestnut, go ahead and unmute your line, introduce yourself, and give us an update from your team. Joe, we're not hearing you.
Hi,
so you may
got me there?
Yep, we can hear you now. Go ahead.
Hello? Hello?
Go ahead, Joe. We can hear you.
You guys have us on here?
Yep, we can hear you, Joe.
Okay. Hi, sorry. Yeah, I'm here with, I'm actually filling in for Michelle, who is our main team lead, and this month we kind of worked together with our hospitalist just to try to get a plan formed. So that's kind of where we're at right now.
Very good. Thanks for being here. Anybody on the line from Virginia Gay? Dan, are you there?
Yes, I'm here.
Go ahead and introduce yourself and what hospital you represent and maybe some of the things that your team's focused on this past month.
Sure. My name's Dan LaGrange. I'm here as the team lead for Virginia Gay Hospital. Over the past month, we've met with our coach, Louis Castigny. I believe that's how you say his name. And he was very helpful in just kind of some background and offering his support for just kind of getting started with the program. We also, all the members here completed a survey just to kind of figure out exactly where we're at when we started. And then we decided that we needed to start with figuring out what some of the policies are that we'd like to look at, some stewardship policies to review, and kind of start putting some of that together. And then we also set up to present to our hospital board and med staff just to get them aware of what was going on and get them on board.
Thanks, Dan. Sounds like a busy month. Great job. Thanks for the update. Jill, are you on the line? Jill Sandy?
Good morning.
Good morning. Go ahead.
From Kika County Hospital in Sigourney, Iowa. I've met with the mentor, Terry. I met with her and got some ideas. She has sent me some things that I'm going through. We kind of had a rough month because we had RAGBRAI come through Sigourney and stay overnight. So we haven't gotten a ton of extra stuff done this month, but I'm hoping to be able to move forward in August and maybe have the group meet in August.
Great, thank you, Jill. And lastly, but certainly not least, Sarah, are you on the line with us?
Yes, I am.
Go ahead and introduce yourself and hospital and give us an update on your work this month.
So I'm Sarah Burns. I'm with Gunderson Palmer Lutheran Hospital. We are located in West Union, Iowa, so Northeast Iowa. We have great backing from our CEO, but I'm having some issues with our providers. So just working on taking one step at a time to slowly update order sets to help providers ease into the transition.
Great. Thank you so much, Sarah, for that update, and all of you for your work this month as you begin kind of assembling your full teams and putting together a plan of action to implement some of these strategies over the next 6 months. At this time, I'm going to ask each of our 4 hospitals to mute your phone lines for the remainder or till the end of the session when Lisa and Jeff circle back to you all. This will help us kind of cut down on any background noise throughout today's presentation. I'd like to introduce today's speakers. Jeff Brock and Lisa Vitale are both members, subject matter experts leading the Swim Towards Stewardship project for the Compass HIIN. Jeff Brock is an infectious disease pharmacy specialist at Mercy Medical Center in Des Moines. He helped create the Antimicrobial Stewardship program at Mercy in 2000 and is the lead pharmacist on this team. Brock also created a postgraduate Year 2 infectious diseases pharmacy residency to train others in antimicrobial stewardship and infectious diseases pharmacotherapy. Lisa Vitale is also joining us, and she's a nurse clinician at the Iowa Department of Public Health, their HAI program, Center for Acute Disease Epidemiology. Her nursing clinical competency spans from infection prevention and control, quality control, behavioral health, surgery, clinic nursing, and outreach nursing. These include areas of cardiac, ENT, and urology. Lisa has her master's in science and nursing with a specialization in IPC. So thank you both, Jeff and Lisa, for joining us. We're going to turn the presentation over to you.
All right, thanks a lot. Thanks everyone for dialing in today. Can you go to the next slide, please? Obviously today we're going to be talking about different measurements that you all can follow for metrics to be able to evaluate your stewardship program. Here's our objectives today. We'll review metrics to track antimicrobial usage, describe the role of the NHSN AUR reporting protocol, and review stewardship quality indicators. Next slide. So, I'm sure y'all seen the CDC Core Elements before. They were presented last month as well. I just wanted to highlight them again today because metrics and tracking and monitoring antibiotic prescribing is part of the CDC Core Elements. It's one of the main things in the Core Elements that we need to really focus on so we can look at the quality of our stewardship program. Next slide. So to kind of just jump right in, I don't use a lot of quotes, but I thought this one kind of fit today by Lord Kelvin, famous mathematician who came up with the Kelvin scale for temperature monitoring. And he said to measure is to know, and really it's very true. I mean, if we don't measure our antibiotic consumption or usage in our hospitals, we really don't know what's going on. So we want to monitor this through different types of measurements. So typically how we do this is get some baseline data of our antimicrobial use or prescribing habits. And then we implement some sort of intervention or education or order set, and then do repeated follow-up measurements to see what happened. And so we can track how effective our intervention was over time. There are three basic types of measures in stewardship. One, we look at the overall quantity or tonnage of antimicrobial use over a period of time. This is usually tracked by month, and you track it over time, month by month, to see if there's any changes. Probably more important than quantity is the quality of antimicrobial use, because quantity only tells you how much you're using. It doesn't tell you if you're using them correctly or not. And so the quality of antimicrobial use is probably one of the most important measures that stewardship programs should actually take a look at. And there are other antimicrobial stewardship measures, which we'll probably get into not so much today, but in a future webinar when we look at pharmacy-related metrics. Next slide. So to kind of jump into some of the measurements that stewardship programs follow, one that always comes up is financial data. Because many people think that stewardship's primary goal is to reduce costs, which really isn't necessarily true. Our primary goal should be to improve overall quality of antimicrobial usage, making sure they're used when they should be and not used when they shouldn't be. However, administrators, particularly the C-suite CEOs and such, want to see financial data to make sure that we might be saving the hospital money over time. So it's one of the most common measures of antimicrobial usage that stewardship programs will follow. You can either follow purchasing data of antimicrobials versus what was billed out for antimicrobials. It kind of depends on what your hospital IT systems can provide you easily. So some examples is total cost of antimicrobial agents. You can break them out by antifungals, antibiotics, different drug classes if you wish, however you want to look at it, or you can just look at the overall cost spent on antimicrobial agents. Another measure is antibiotic cost per patient day, which is a little bit more difficult to capture. You need help from IT to capture that measure, along with the antibiotic cost per patient admission. Those are a couple of commonly used measures you can follow if you're streamlining antibiotics efficiently in your patients, making sure they're not using multiple agents that way. So the overall goal there is to reduce the cost per patient or per admission. Another one is a total hospital cost per admission. I think this one has a lot of problems, so it's not one that's routinely recommended because there's a lot of different factors that weigh into the total cost per admission, and not just related to antimicrobials. So that's one that's not routinely monitored. So some of the pros of financial data is usually easily obtainable through your hospital IT systems because costs are generally tracked month to month. This is one that's often tied to institutional stewardship goals. Most of the studies that have looked at financial data have proven that stewardship programs are self-sustaining, and the fact that most programs save the hospital money with respect to antimicrobial use and actually pay for the time involved for the pharmacist and if there's a medical director involved in the program. The benefits of introducing these financially are far outweigh the actual cost of the personnel and to put these programs on. And financial data can likely be a win. So, you know, this is one measure that I try to avoid as much as possible, because sometimes we actually increase costs. For example, if you have a strep infection and the patient's on oral levofloxacin, which is fairly cheap, but you know, this is an invasive bloodstream infection and you want to use IV penicillin. IV penicillin is a lot more expensive than oral levofloxacin. So sometimes the more simpler antibiotics these days are unfortunately more expensive than some of the broader spectrum agents that we have. So sometimes we actually increase cost of care, although that's the right thing to do for stewardship. Some of the cons, you must remember to consider changes in pricing, contracts, and et cetera, because those can change from month to month. Next slide. So another metric that we is routinely followed to look at the quantity of antimicrobial usage is a thing called the defined daily dose, or you'll see it abbreviated as DDD. The target audience on this, again, is administrators and even epidemiologists and other medical staff. This is a measure that's been standardized by the World Health Organization. It's a definition of what the normal daily dose of an antimicrobial is. However, it doesn't necessarily reflect the recommended or the generally most common prescribed daily dose. For example, those of you that use daptomycin in your hospital, it's a weight-based dose. And the defined daily dose for the World Health Organization is 0.28 grams or 280 milligrams. And so that's a really uncommonly used dose. And really the dose of this drug depends on the patient's body weight. So that's one of the downfalls of this particular measure. It doesn't always correlate to the most commonly used dose. Another thing, you have to have a correction factor. And one of the most commonly used correction factor for this measure is defined daily dose per 1,000 patient days. And so you figure out how many patient days of experience you've had over the previous month, and then you can calculate the defined daily dose for each one of your agents that you're following. You don't have to follow all antibiotics with this measure either. You can, if you know your top 5 to 10 antibiotics, then you can start tracking the defined daily dose for those particular agents over time. And particularly if you're having, you know, if you're focusing your stewardship efforts on maybe reducing carbapenem use or something like that, then you can follow the defined daily dose for carbapenems. So what you figure out is how many grams of whatever antibiotic that you use for the month. You look up the defined daily dose on the World Health Organization website, and you just do simple math. And so you can see an example there, which I use for levofloxacin. So the defined daily dose for levofloxacin is a half a gram. And so if you use 125 grams over the month, you divide that by 0.5 and you get 250 DDDs. And then you use your correction factor for patient days experienced that month. And then the overall DDD per 1,000 patient days for that would be 208. Next slide. And so some of the pros and cons of DDD. Pros, it's a standardized comparison using aggregate utilization data, and it's defined by the World Health Organization. So you can actually compare hospitals across your state, health system, and even across the world, because it's a standardized measure. And so it can be used for benchmarking. And it's a relatively easy thing to calculate. There are several cons to this measure. It can't be used as a surrogate for days of therapy when the dose is different than the standard. And so and the DDTs can actually change over time. So if the definition changes for antibiotic X, your measure is going to change. And so it's a little bit harder to benchmark in that situation. Next slide. Another measure of quantity of antibiotic use is something that's called days of therapy. And this one is probably, it is actually the one that's been recommended mostly for stewardship programs to follow by various organizations. And this one's a little bit different than defined daily dose. Days of therapy is a sum of days for which any amount of an antimicrobial agent was administered to a patient. So the nice thing about this, it doesn't take into consideration the dose or the dosing frequency. And so, as you can see here with my example of vancomycin, if a patient got 1 gram every 8 hours or 1 gram every 24 hours, that represents 1 day of therapy. So as long as the patient is on an antibiotic that day, that counts for 1 day of therapy. So in the next example, if the patient's on 2 antibiotics, such as ceftriaxone and azithromycin, if the patient has community-acquired pneumonia, that relates to actually 2 days of therapy each day that that patient's on that combination of antibiotics. So it'd be 1 day of ceftriaxone plus 1 day of azithromycin. This one's a little bit harder to calculate because the best way to do this, and really the only feasible way to do this, is making sure that you have data that you can obtain this data from the electronic medical record, or EMR data, so electronic MAR administration data, or barcode medication administration data. Next slide. So just to put these two in perspectives, put the pros and cons of each on one slide so you can kind of compare. I'm not going to go through each one of these because I've already talked about some of them. But another con of the defined daily dose is it's not accurate for pediatrics. So if you have many pediatrics in your institution, you know, obviously the dose is a lot lower than what the defined daily dose is from the World Health Organization. So that can really impact your DDD calculations, as well as if you have a number of patients with renal insufficiency. So it's a little less accurate than the days of therapy calculation for those situations. As I said, the days of therapy is endorsed by several organizations. It is endorsed by the CDC and NHSN as a viable measure for your stewardship program. And so the days of therapy is actually has become the preferred method really to follow if you have the capability to capture this electronically. If you don't have the ability to capture it through your electronic health record, then defined daily dose is an acceptable alternative. One con that I didn't mention for days of therapy is it actually favors the use of broad spectrum antibiotics over narrow spectrum combination therapy. For example, if you had a patient with acute appendicitis that's been treated, maybe they had a gangrenous appendix and they're using antibiotics post removal of the appendix, and the surgeon decided to use some pip/tazo or Zosyn, which is a broad spectrum antibiotic. If you're looking at days of therapy and the patient got 7 days, that results in 7 days of therapy pip/tazo. But a more narrow approach would be using ceftriaxone and metronidazole. And if you use the 7 days, that actually accounts for 14 days of therapy of antibiotics. And so this measure can, favors the use of broad spectrum antibiotics versus narrow spectrum, but so that's just one thing to keep in to consideration when you use this measure. Next slide. This is a study that was initially done with days of therapy versus defined daily dose by Ron Polk. He's up in Minnesota. He's a pharmacist. He was initially the person who came up with this days of therapy calculation. You can see that when comparing it to days of therapy and defined daily dose, is that there are differences. Generally, the days of therapy reports out a little bit higher than the defined daily dose. So just a visualization of how different the two measures can be. But what's important is that you use the same measure consistently to track. And so they're both decent ways to track overall consumption over time. But you need to make sure you use the same method and the same correction factor when you do the calculations, just to make sure that you're doing it the same way, and then you can track your antibiotic use over time. Next slide. So I talked a little bit about this correction factor, or the denominator, you need to use this denominator or this correction factor to account for essentially changes in your census in your hospital. As we know, some months are busier than others, particularly the winter, when you're really busy with flu and pneumonia patients, as opposed to July when you might be a little less busy. So you need this correction factor to standardize your measurements month to month. Next slide. So some of the correction factors you can use are admissions, or number of patients admitted to the facility on the first day of each month through the calendar month. Another correction factor you can use are patient days. And so that's a kind of a daily count of the patients in whatever patient care location or in your hospital at a particular time period each day. And then you tally those up, and that's your patient days for the month. There's another one called days present. That's the number of patients present in a given location for any portion of the day. You can use any one of these, but just, again, you have to be consistent. The more common measures here are patient days of experience or the present. Most facilities are using one of those. Working with infection prevention in your hospital, they typically have some of these numbers available because they present their rates and numbers to NHSN for various different nosocomial infections. So become friends with your local infection preventionist, and they can help you get these numbers easily. Next slide. So, I mentioned a little bit a while ago that quantity is one thing of antibiotics, but quality is really the most important measure. So quantity of antibiotics doesn't really relate to the quality of the antibiotics used in your facility. So you need to figure out a way to monitor the quality of antimicrobial use. So what antibiotics are being given for certain infections that you're interested in? Are the antibiotics prescribed in compliance with your local or national prescribing guidelines? Another thing you can look at is total duration of antimicrobial use for whatever indications that you want to look at. One common example would be for post-op surgical prophylaxis. How long are the surgeons giving antibiotics post-surgery? And that tells you a little bit more information, not just the total quantity. It tells you, if you're in compliance with national and local guidelines. Ways you can do this are using some audit tools. Pharmacists refer to these as MUEs, or medication utilization evaluations. You can also use point prevalence studies, where you go and look at everybody in the hospital with pneumonia and see what antibiotics those patients are on. So those are two common ways that you can start to get at some of the quality of use in your facilities. Another common would be the urinary tract infections is an easy target to look at as well. Next slide. This is a study that was published not too long ago. It was a group of experts with regard to antimicrobial stewardship and metrics. This group of people, healthcare professionals, use this modified Delphi approach to select relevant metrics to assess the stewardship, the quality of interventions in acute care settings, with the sole purpose of trying to make your program better and to help give you more data for decision making. So this panel, they rated 90 different metrics on a 9-point Likert scale, and they used the four criteria that you see here as the basis of making the recommendation. So did it improve antimicrobial prescribing? Does it improve patient care? What kind of utility in targeting stewardship efforts does this metric have? And is it feasible in hospitals with particularly electronic medical records? Next slide. So this is the outcome of their analysis. So looking at clinical outcomes, unintended consequences, looking at utilization of antimicrobials, and looking at the process measures relating to stewardship. So the group 1 column, those metrics are ready for immediate use and tracking in antimicrobial stewardship programs. So, looking at clinical outcomes, which is kind of the holy grail of antimicrobial stewardship, that's what we're trying to do. We're trying to improve clinical outcomes. But what measure do we follow to say that, hey, our stewardship program's improving clinical outcomes? Really, there's really nothing available right now that's recommended for immediate implementation into your program, because there's a lot of different confounders with this measure. They have identified one that might have some potential utility in the future, and that's readmissions related to infectious diagnosis. But if you want to look at clinical outcomes in your stewardship program, that's a difficult beast to tackle right now. There's nothing that's been recommended that's solid for us to follow with respect to stewardship and clinical outcomes. However, if you look at unintended consequences, Clostridium difficile infections, either if it's healthcare facility associated or hospital onset associated C. diff, those are two measures, or a measure which you can track and has quite a bit of meaning in your stewardship program, as well as tracking drug-resistant infection rates over time in your hospital. Again, looking at utilization, we've already went through the days of therapy per admission or days of therapy per patient days. Those are two measures that are ready for immediate use by programs. And looking at process measures, meaning that, when your pharmacists or your physicians are doing their stewardship program, what events do we want to monitor? The one that's ready for immediate use are redundant therapy events. So what this means is if you had a patient admitted with community-acquired pneumonia that was on both levofloxacin and azithromycin, that would be a redundant therapy event. Another one, if you had a patient with an intra-abdominal infection that was on Zosyn plus metronidazole, that's double coverage of anaerobic bacteria, which is not needed when you have Zosyn on board already. And so those are redundant therapy events, and those are measures which your stewards can follow, how many times they've had to intervene on those types of antimicrobial use issues. I won't go through all the group 2 tracking measures. You can read those on your own, but those are all potential areas for study in the future and maybe implementation at a future date. Next slide. So a little bit on drug-resistant infections. This is a common one that I hear people want to track. So we do want to prevent in our programs the development of resistant infections over time. That's one of our core missions of a stewardship program. Most of you probably have an antibiogram that you follow on a yearly basis in your facilities. This is helpful for tracking local resistance, particularly in your community and your hospital. But antibiograms cannot totally be attributed to the hospital exposure because many acquired isolates are included in antibiograms, community onset infections and things like that. And it's very difficult to detect an effect on your local antibiograms by introducing a new stewardship measure because of all this community onset infections. You can go to the next slide. So you want to make the data actionable. You want to refine your data. So drill down on certain questions that you have. Talk who's prescribing the antimicrobials. What's the most frequently used antibiotic? Start asking questions. So just because you track your overall usage for the month, that doesn't tell you a whole lot. You need to start drilling down on specific questions that you have. How are different infectious syndromes being treated? Is that consistent with guidelines? Why are people using these antibiotics? Those are really what we need to really track and get metrics around. And that way we can have more conversations which are productive with your medical staff and providers. And you can create guidelines with input from your local providers. And if you get input from your providers, then they're more likely to follow your guidelines. And always ask why certain things are being done or used, because the reason behind that use may not be what you had guessed without talking to your providers and med staff. Next slide. So now I'm going to turn it over to Lisa to talk a little bit about the AUR program.
Thanks, Jeff. I'm going to be going over describing the role of NHSN AUR reporting. And basically, it's an internet-based secure surveillance system that is managed by CDC's Division of Healthcare Quality Promotion. It collects reported data on antimicrobial use and resistance. It permits recognition of trends, and it provides healthcare organizations with data which is used for interfacility comparisons leading to quality improvement activities. Next slide, please. And the link to the AUR module can be located in the chat thread. So antimicrobial usage option. The purpose is to provide a mechanism for healthcare organizations to report and examine antimicrobial usage as part of stewardship efforts. It's voluntarily reporting, as this option is not part of the CMS quality reporting program. Next slide, please. AU participation. So healthcare organizations, they have to either have electronic medication administration record, the EMAR, or barcoding medication administration, BCMA system, and the ability to collect and package data using the Health Level Standard 7 format, which this document is also located in the chat thread. So I wanted to present some statistics on AUR. So this data is as of May 1st, 2018. So there were 805 healthcare organizations that submitted at least 1 month of data. The teaching status is 65%. The bed size average is 215 beds. The medium is 168. The minimum is 6. The maximum is 1,455. There were 326 healthcare organizations that submitted at least 1 month of AR option data. The next slide is a visual of this data. And so the data as of 2012 has significantly increased. Next slide. I also wanted to give you a visual of the national data and some strong state participants. Utah is at 48%, Virginia's at 33%, and Oregon's at 25%. So this is the percentage of facilities ever reporting to NHSN AU option as of May 2018. I was at 2%. Next slide, please. This slide is the percentage of facilities ever reporting to NHSN the AR option as of May 2018. And Florida is at 19%, Virginia is at 14%, and there's a few other states that are at 12%. Next slide, please. So I'll talk to you a little bit about the antimicrobial resistant option. So the purpose is it enables the evaluation of antimicrobial resistance data using a standardized approach. It affords healthcare organizations with improved awareness of a variety of AR issues to aid in the clinical decision-making process, which would be like hospital antibiograms and the assessment of cross-transmission. And it enables the priority of prevention efforts. Next slide. Now for this option, healthcare organizations also need either the electronic laboratory information system and admission discharge transfer system, or the electronic access to required data elements and the ability to collect and package data using the HL7 format. So the standardized antimicrobial administration ratio, it's a benching measure for antibiotic use. The SAAR expresses observed antibiotic use compared to predicted use. There are SAARs for different populations, such as the adult, ICU, peds, non-ICUs. There are SAARs for different groups of antibiotics, so agents pertaining to healthcare-associated pathogens, community pathogens, agents that are active against MRSA, surgical prophylaxis, and all antibacterial agents. Significant points to a SAAR. The SAAR will only help direct stewardship efforts for locations and antibiotics where use appears to deviate from the expected. So high use of antimicrobials may be justified, although low use might be harming patients. So a SAAR can be produced either monthly, quarterly, half year, or yearly. And this is just a visual of the metric. It's calculated by the observed antimicrobial use by the predicted antimicrobial use. So observed to predicted ratio, the observed antibiotic use is the days of therapy reported by healthcare organizations for a specified category of antimicrobial agent in a specified patient care location or groups of location. Predicted antibiotic use, the predicted use is days of therapy predicted for a healthcare organization's use of a specified category of antimicrobial agent in a specified category of patient care location or group of locations on the basis of negative binomial regression modeling applies to nationally aggregated AU data. So here interpreting SAAR values. So the SAAR is a ratio. The calculated SAAR value is always greater than or equal to 0, and a value of 1.0 suggests equivalency between observed and predicted antimicrobial use. A SAAR less than 1 may indicate antibiotic underuse. A SAAR of 1 indicates that antibiotic use is equivalent to the referent population's antibiotic use, and a SAAR greater than 1 may indicate excessive antibiotic use. A SAAR alone is not a definitive measure of the appropriateness or judicious of antimicrobial use, and any SAAR may warrant further investigation. For example, a SAAR above 1 that does not achieve statistical significance may be associated with meaningful excess of antimicrobial use, and further investigation may be needed. Although a SAAR that is statistically different from 1.0 does not mean that further investigation will be productive. So in conclusion, there are multiple ways to measure antibiotic use, each with advantages and disadvantages. You should choose one measure of antibiotic use. Things to consider is institutional versus patient level data, availability and ease of collecting the data, and tracking measures beyond antibiotic use to track efforts. So basically individualized to your situation.
Thank you so much, Lisa. This is Kate Carpenter, and I'll take back briefly the webinar. Before we get into next steps, we've allowed some time at the conclusion of the webinar today to check back in with each of our hospitals participating in the fishbowl to get some of your reactions and thoughts about the measurement content presented today, while we have both Jeff Brock and Lisa Vitale on the line to field those questions. So some things maybe that we'd like to get your thoughts on are, you know, what if anything are you currently measuring after hearing this content today? Is there a particular measure that you think you might like to start with? When you see all this information presented, you know, as a big chunk, sometimes it can seem like a lot, or where do we start with this? And we don't want you to feel like you need to swallow the ocean, so to speak. So pick what makes sense for you, what data is accessible to you, what purpose might it serve. So we'd love to get some of your thoughts on that. And then if you could just fill us in on if you currently have an antibiogram and how you're using it, we'd love to hear your thoughts there. Jill Sandy, could we start with you? Are you with us? Go ahead and unmute your line.
Hi. We were just discussing this. We are so tiny that we decided that really and truly what would probably be the best thing for us to start with is the antibiotics we actually use, building a spreadsheet of the antibiotics we actually use, patient days of the antibiotic use, and who's prescribing it, so we can get a better handle on who's prescribing. Oh, and also I feel like what the indication is.
so we have a better idea of who's prescribing which antibiotics, how many patient days, and what the antibiotic is being prescribed for.
That's great. Thanks, Jill, for sharing. Jeff, do you have any kind of response back to Jill's ideas and thoughts there?
I think that sounds like a good place to start, honestly. You know, you have to do what fits your hospital. If you're a small hospital and you only have, I don't know, 5 patients and only 1 or 2 are on antibiotics, I mean, you could.
That's
you
us.
That
Is
yeah,
us.
I mean,
Yeah.
yeah, I know a lot of the rural hospitals, you know, don't have a ton of patients, and I followed a few of them, and you know, there might be 1 patient in the day on an antibiotic, and it's pretty easy to track, you know, who's using it, and you know, making sure that whatever.
We maybe have 5 per month.
Oh, really?
Yeah.
Yeah, so you you probably don't need IT help. You can probably do that by hand, and it's not a huge burden.
Pretty much.
Yeah.
Yeah, we're a 14-bed critical access hospital, and yeah, 5 per month, and that's maybe during our busy season, which is, I don't know, we maybe have more. We maybe have 15, 20 during the winter months, but this time of year, we're about lucky if we have 5. So.
Yeah, what I tell people is you got to do what fits your hospital. I mean, what works for us at Mercy, I mean, I couldn't obviously track each one by hand here. We have about 250 patients a day on some sort of anti-infective.
Sure.
What works for me and won't work, you know, doesn't make sense for you. I mean, if you can by hand easily, I think it sounds like a good plan.
Yeah. Okay. That's what we'll plan on doing.
That's great, Jill. And I think this is, some of the benefit of the fishbowl is to be able to have some of this live conversation and really be hearing from hospitals of all sizes, you know, how you might implement this. And so knowing you might do some of this tracking by hand, do you think that as the next month progresses, before we get to webinar 3, that those are some things you might be able to get started?
Yes, I think what we'll do is we'll go all the way back to January, try to pull some stuff all the way from January, and try to, so we can get a historic tracking for us, and then moving forward, definitely every patient.
Very, very good. And I know as you start to track some of that preliminary data, if it's helpful to reach out and share some of that with your coach and get some of their initial reaction and feedback and direction, please, we welcome you to do that. Let's go ahead and move over to Sarah. Sarah, are you still with us? Can you give some of your thoughts?
Yep, I'm still here. I know that we have access to some, with Epic, since we're through Gunderson, we have access to some reports. I just don't currently use them, so I'll definitely be looking into kind of which ones I do have, you know, available to me. We also don't, I mean, our small critical access hospitals, so I probably could do this by hand as well. Our infection preventionist already does report on like C. diff and those type of things. So I'm definitely going to get in touch with her and kind of find out what she already does so that we're not duplicating, and then maybe the information she gets that we could just build on.
Yeah, that sounds great. Jeff and Lisa, I'll give you a chance to respond to those thoughts.
I'm sorry, I had the doctor kind of interrupt me.
No worries. She was just saying that, you know, she's a part of a larger hospital system, so she's going to sort of see what report types might already be available that she could use, and also sort of take an inventory of current existing efforts taking place in the infection prevention department of the hospital, and see if they can sort of collaborate on pulling together some of these data points. So I think those are great ideas, good places to start.
Yeah, definitely. I mean, starting at IT is a good spot because honestly, the IT's, hopefully there's no IT people on the line here, but they've given me a lot of headaches over the years because it's, you know, not necessarily their fault. It's the kind of the issues with our EMR systems and what can be pulled out of it. And so starting with IT is a good spot, just so you can figure out what's the feasibility of getting some of these reports out of your system. Because if you can't get it, you can't really track it. It's not really feasible for the larger hospitals to track everything by hand. So I think starting with IT and visiting with infection prevention, they're lifesavers over there usually. They have a lot of data that can be useful for stewardship. They actually can help you with project implementation if you're looking at reducing C. diff and things like that also.
Yeah, great. Thank you so much, Sarah and team at Gunderson. What about checking in with Dan LaGrange? They're at Virginia Gay Hospital.
Yeah, I think kind of what both Jill and Sarah had said. We have some real similarities there with having a small patient group that we could kind of create a spreadsheet to see, definitely to track days of therapy. I think that would be something that we could do fairly easily. And then we're also an Epic hospital, so reviewing some of the reports that are already available to us in Epic is good. We're also going to work on getting something similar to an antibiogram for our area at least.
That's great. That's great. I know Dr. Castagnini has joined us, and I'm sure he's cheering for that. So thanks, Dan, for sharing. And I also want to touch base with Joe Chestnut for the Clark County team and see what thoughts you guys have as you listen in today.
Yeah, I agree with all you guys. We're kind of a smaller hospital, and we're also with Epic, so we can definitely use the reports that we can generate from Epic. And I know that Michelle is using the antibiograms, and I can do some work on my end, being the infection prevention, and kind of link up with her and watch our C. diff rates and see if there's some correlation there. And we do only have one hospitalist in-house at all times, so it'd be pretty easy to track who's prescribing everything. So that sounds like something we could do. So.
Yeah, great. I think all of you have really identified just some areas to start with, just some manual hand tracking. I know that there's some things even you can sample as far as a place to start. The hard thing is sometimes the starting. So, if you're listening today with your teams, take a couple minutes to say, what's our next step before we leave this room today? In regards to measurement, what's our next step? What could we do this month? Who can we assign that task to? Who could go talk to IT for us? Who should we send down to infection prevention, et cetera, to start getting some of those denominators that might help us out. So most definitely. I want to encourage you all to email your assigned coaches this week for our hospitals that are participating formally in the fishbowl, and set up a time, schedule a time to meet up with them this month so you can get their support. Again, just enunciating the jump in and start implementation. Make sure your team is registered for webinar 3. This tends to be a busy time of year as kids start back to school and a lot of fall activities start. So try and send that date and registration link out to your team so they've got that time held for webinar 3 on September 19th, again at 11 o'clock. I want to encourage you to please reach out to me if you have any programmatic questions as far as registering for webinars or any resources you need. We've got a large subject matter expert team collectively supporting this project, and I know they'd be happy to help you this month. As an example, we had some requests for sample policies, and we were able to push those out to the group. So we appreciate those requests coming in. Jeff, I'm going to hand it back to you just for any closing comments as we close out today's session.
I just want to thank everybody for listening in, and feel free to reach out to me if you have any questions about metrics or anything else with stewardship, and reach out to your team lead first. But I'd be happy to talk to anybody about metrics if there's specific questions. So thanks for your time.
Very good. Have a great day, everybody. Thanks for joining.
Thanks, everyone.
Thanks, guys.